Hello, my name is John Hayes. I am a family medicine and addiction medicine physician that works for the Medical College of Wisconsin. My educational mission, one of the things I'm passionate about, is training people how to help people that use opioids. Um, I started out as a regular family medicine physician. In my residency, I chose a program in Chicago that just happened to be across the street from an open air drug market in kind of the peak of when the opioid epidemic was really starting to heat up in the city of Chicago. So during my residency training, I really saw patients overdosing fairly frequently in the hospital, people coming in with abscesses and endocarditis. I was seeing really the devastating effects of opioid use disorder. But unfortunately, none of the attendings I worked with really knew how to care for opioid use disorder. I was just stuck with an extremely unsatisfying referral to methadone clinics. I knew often were either expensive or the patient wasn't going to go to. I knew that in methadone clinics, people weren't getting any primary care services, and they would often choose the methadone over their primary care. So I thought there must be another way. And that led me to learn all about buprenorphine, which kind of became a passion of mine, office-based opioid treatment, and that's what I'm going to tell you about here in this lecture. I'm going to break this lecture into three different parts. There's the epidemiology, there is the harm reduction for people with opioid use disorder, and then I'm going to go through two different cases, a kind of patient with a moderate use disorder and a severe opioid use disorder. So my hope is that you will, by the end of this training, really have the foundation to be a competent opioid prescriber. I've been an addiction medicine physician now since for the last 4 years, and I am passionate about this work, and I find it incredibly rewarding, and I hope you will feel the same by the end of this training. So I'd like to stress at the beginning of this course that this is not a formal buprenorphine waiver training course. Under the old law, anyone that wanted to prescribe buprenorphine in an office setting needed to complete an 8-hour training. Um, that 8-hour training still exists. The easiest one for people to access is the one that's available for free on the PCSS, that's the Provider Clinical Support System um, website that's here at the bottom of your screen. But in April 2021, the Biden administration said that you actually don't need to take that 8-hour class anymore to prescribe buprenorphine to up to 30 patients. And even better, if multiple people in your practice have this same waiver, you get to pool. So say you work in a residency training site and all of the residents have bup waivers. That means you could treat hundreds of patients in your group practice, and you don't really have to worry about who's prescribing to who. It's also important to note that that limit is 30 active scripts, which you can monitor through the PDMP. So if you've prescribed to 70 people in a year, but 30 of those people have transferred care, or 30 or 40 of those people have transferred care, then you're going to be fine. You're not actively prescribing to 70 people at one time. In order to start prescribing buprenorphine, all you have to do under the current law is Google buprenorphine NOI form, and that will bring you to the SAMHSA website that lets you fill out a very quick online form, takes 10 minutes, and then you'll get your DEA-X license, which they just changed the first letter of your DEA license to an X. And then you can immediately start treating people that need this help for opioid use disorder. It's important to point out that if you want, under the current law, to prescribe to more than 30 patients, I think the limit currently is 275 patients. You do need this full 8-hour buprenorphine waiver training course. Although there is national legislation currently working its way for Congress to abolish the buprenorphine waiver, which makes a lot of sense to me. There's no legislation that restricts my ability to prescribe oxycodone to a certain amount of patients, so it probably doesn't make any sense to limit the amount of buprenorphine I can prescribe to patients. So that's just my disclaimer here. Not a formal buprenorphine waiver training course, but if you attend this, you're going to have all the tools needed to really be an effective office-based or even hospital-based prescriber of buprenorphine for patients that are living with opioid use disorder. So the reason why we're doing this training is that in the US, the drug overdose crisis, it is the worst it has ever been. Over 100,000 people died of drug overdoses in between 2021 and 2022 and 2022 and 2023. Every year, we're seeing over 100,000 deaths for the last 3 years. That's a pretty distressing stat. We saw a big rise of overdoses during COVID, but that number has continued to climb. There's not enough prescribers in the US to tackle this problem. We need all hands on deck. We need primary care physicians, we need hospitalists, we need ER doctors, we need OB-GYN doctors, anyone that can possibly care for people with opioid use disorder really need to start to, one, care for the people with opioid use disorder. I'm also going to talk to you a little bit about harm reduction so that we can help prevent some of those accidental opioid overdose deaths. So I've heard from a lot of people this idea that the opioid crisis is a somewhere else problem, right? That's like something in West Virginia that they're trying to address, but this isn't really our issue. But unfortunately, that's just not at all the case. Wisconsin has seen an increase in drug overdose deaths over the last several years. We're also seeing an increase in emergency room hospitalization and death. And it's not just a Milwaukee urban problem. We're seeing that across the state, particularly in rural counties as well. So we know this is an everywhere problem, and that docs anywhere in the state of Wisconsin or in our surrounding area in the Midwest are all particularly afflicted by this opioid overdose crisis. So a particularly sad statistic that's put out by the CDC says that 3 in 5 people who died from overdose had some kind of opportunity for linkage to care or life-saving action before they died. So this is a patient coming to their primary care doctor and saying they have a problem with opioids, or someone going to the ER with their first overdose, or telling a counselor that they're struggling with addiction. What we need to do in healthcare to help stem the flow of really intense overdose death is to start to intervene when people are asking for help. Intervening doesn't really mean making a referral anymore. It means actually offering help to the people that need it most. We know there are a lot of people in the US that need help. The Substance Abuse and Mental Health Service Administration estimates that 22 million people in the US have a substance use disorder, and only 10% of those people diagnosed with substance use disorders receive any type of addiction treatment. Now, of course, there are probably some people in this group that don't desire treatment, but I think we could do a lot to solve this significant care gap and offer treatment to more patients to really start to improve outcomes. So if people aren't getting treatment, what are our predominant treatment modalities for substance use disorder? Well, unfortunately, in the US, the answer to substance use disorder has been mass incarceration. Since the 70s, we saw prison populations massively expand. We know that most people that are incarcerated, 68% of all jail inmates, 50% of all prison inmates had diagnosable substance use disorders, and that likely led to their incarceration. So mass incarceration has been our answer instead of medical treatment.
We also know that the criminal justice system doles out its punishment in a biased and unjust manner. So if you look at the discrepancy between white and black patients in the US, it's particularly glaring. We know that white people actually use slightly more drugs than black people in the United States. They sell drugs at similar rates. But black people are 6 times more likely to be incarcerated for substance use. And that is really significant because people that are incarcerated for substance use also have a higher incidence of death from opioid overdose. So what tends to happen when you have an incarceration for substance use disorder is you get forced to go through detox, since most of the criminal justice system does not treat people with substance use disorders. So people lose all of their tolerance. And when they get out, they resume use of the same fentanyl adulterated unsafe drugs that we have in our market. And they, instead of just using and getting high like they used to, they use and die. There is a 40 times increased risk of dying from an overdose when you're recently out of the criminal justice system, when you're recently released from jail or prison. So that's a really shocking discrepancy, that we're unfairly incarcerating large amounts of the African American patient population. That doesn't even discuss the significant issue with giving people felonies for drug crimes. So my patients will frequently tell me that they are having trouble getting housing because they have felonies on their record, that they are having difficulty with employment, that they're trying to rebuild their life, but they have a felony drug possession and nobody will give them a job, no one will give them a chance. So instead of helping rehabilitate people, instead the criminal justice system literally increases the risk of overdose and decreases the risk of rehabilitation. It does the exact opposite of what it claims to do.
Fortunately, we also see some pretty big disparities in access to medications like buprenorphine. On racial lines, we see that Black patients are much less likely to be offered medication-assisted treatment with meds like buprenorphine as compared to white patients. We also see that privately insured patients are also much more likely to be able to access medication-assisted treatment than people with Medicaid or Medicare. So we still have a long ways to go in creating an equitable system to care for patients with substance use disorders. So we know that mass incarceration is ineffective. We know that medication can really help patients with substance use disorder. So why aren't more people getting the treatment that they need? Well, if you look at the stats, it's pretty clear. Less than 6% of all physicians in the country have a buprenorphine waiver. And around 40% of counties in the US have no doctors that are waivered to prescribe buprenorphine. And this is even after the recent administration made it easier for people to obtain their buprenorphine waiver. So there's this highly effective medication that can really significantly improve outcomes, but we have physicians that are just not willing or able to step up and prescribe that medication. So something has to change here. We need to have more doctors that are willing to provide this care if we're going to make a difference in our society.
I just want to be really clear here. The standard of care for treating opioid use disorder is medication-assisted treatment. It's not detox, it's not abstinence, it's not equine therapy. All people need to do is get on these medications. They're highly efficacious. They drastically reduce the risk of overdose. Buprenorphine and naltrexone can be administered in a primary care office. Naloxone should be distributed pretty much everywhere, and the newest update is that naloxone will be soon available over the counter. Methadone has to be dispensed in a specialized clinic, and we're going to get into that in a little bit. But the truth is, these medications are not particularly complicated to prescribe. You do not need to be a specialist. You don't need to have years of training. You don't need an extensive support system. You don't need a psychiatrist or psychologist as backup. These drugs have very simple dosing and very simple administration routes. They're drugs like insulin or blood pressure medication or asthma inhalers. Those medications are much more complicated than the medications we use to treat opioid use disorder. So there's no excuse. Complexity is not an excuse. We must make medication-assisted treatment more mainstream in order to combat the serious crisis of opioid overdose deaths in the US. Treatment with medication for opioid use disorder drastically reduces mortality. So patients with opioid use disorder are roughly 6 times more likely to die than patients in the general population. Medication-assisted treatment cuts this by close to 80%. So they're less than twice as likely to die than the general population. It's really rare to find any medication in medicine that has this much risk reduction. These treatments are safe, they're highly efficacious, they save lives. And what's really important to point out is that they not only prevent overdose mortality, but they also prevent all-cause mortality. Because when people are maintained on buprenorphine or naltrexone or methadone, they're able to live their lives. They're able to take a blood pressure med, get their mental health in order, take care of their nutrition, take care of their cardiac conditions, prevent their seizures. This treatment allows people to live their lives and significantly reduces all forms of mortality. It is one of the most powerful interventions we have in medicine. And again, it must be more mainstream.
So sometimes what you hear people say is, do we really need opioid maintenance treatments? Do we really need to prescribe people buprenorphine for long periods of time? Why don't we just get them to stop? And this is kind of a misguided attitude that the US healthcare system has taken for a really long time. Let's just detox somebody from the opioids, help them through their withdrawal, and they're going to live happily ever after. Well, unfortunately, we know this is a harmful practice. In major studies, approximately 80% of patients that detox will resume use within 1 month of that detox. But we also know that 3 to 7 days is all it takes to lose your tolerance to opioids. So many of those patients that are going into detox are losing their tolerance, and when they resume use, they die or they overdose. They end up in an ER, they get an aspiration. So the practice of detoxing people off their opioids is actually a directly harmful practice and should not be attempted. The standard of care is getting people onto medication-assisted treatment and keeping them stable on that medication for the long term. They can't just stop. So I'm going to tell you something that you should not do is you have to be really careful with the language that you have with patients, particularly right after overdose or when they're in the middle of their use. So imagine the scenario. You wake up from an overdose after your naloxone administration. You look up at a bunch of faces and everybody's making judgy statements. You're harming yourself. You need to get clean. You could have died. It's just no one really wakes up from an overdose and says, you know what, docs, I'll stop. I didn't even think about this before. Thank you very much. I'm just going to change my ways. People know they need to stop. What they need is they need help. They need support. They do not need a lecture, and actually lecturing them has directly adverse effects. Society is pretty heavily anti-drug. It is omnipresent in advertising. They get it. People get it in school. They get it in their own families. You're not helping the person by telling them drugs are bad. They know. What they need is support. They need a plan. They do not need a lecture. My point here is that when we lecture a patient, we make them feel guilty. When they feel guilty, their brain is wired to want to use drugs to feel something, to help them cope with their crappy lives and everything that's happened to them. So by making them feel guilty, you cause them to have more cravings, and when they have more cravings, they're going to use more drugs. They're going to feel worse about themselves. They're going to be in worse psychic and sometimes worse physical pain, which causes them to use more drugs and feel bad and worse about themselves. So this shame spiral is often what leads people towards death, right? The escalating use, because people feel like, you know what, I'm using anyway, my life is worthless, I'm just going to throw it all away. You don't need to contribute to that. You can stop this by breaking that cycle of guilt and being empathetic and helping a person take the first step on their recovery. So we can help people by really just being mindful about the terminology we use, and not just in front of them, but also in the call room and in our notes. So one great example is they've studied the use of the term substance abuser versus substance use disorder. In clinical vignettes, when a patient was written as a substance abuser, clinicians felt that a patient was less likely to benefit from treatment, should be punished, was more socially threatening, and is more at fault for their drug use. But in that same vignette, if you wrote it as a patient having a substance use disorder, clinicians felt that that person would be more likely to benefit from treatment. So you can see by inserting that little negative statement, substance abuser, people are much more likely to stigmatize the substance abuser. Our goal here is to build people up and help them break that cycle of addiction, and we have to eliminate all negativity from our language in order to do that. So we need to be really mindful of all the language that we use with patients with substance use disorder. Examples. This idea of using person-first language is really important. Saying drug use, not drug abuse. Saying person living in recovery, not an ex-addict. Saying person arrested for a drug violation instead of a drug offender, a chronic drug offender, felon. You can see how the negative language can actually significantly cause adverse effects in the treatment course of a patient. One big one I like to stress is it's not a dirty urine, it's a positive drug screen. It's not a clean urine, it's a negative drug screen. Saying dirty and clean implies the drug user is dirty or clean, and that can be directly harmful to the person. So be mindful of the language that you use around patients, because that actually can affect their care. It can affect their self-confidence, can make a treatment successful or unsuccessful. So one of the things I like to talk about when I'm trying to make a case for more physicians to prescribe medication-assisted treatment in their practice is to look at where the drugs are coming from. Is there any physician responsibility here for us to help solve this epidemic? Well, if you look categorically where people are getting non-prescribed opioids, it's almost always from a friend or relative for free. What that means are there's pills sitting around the house that people are just giving out because they just have too many of them and they don't know what to do with it. But what we see over time is that if you look longer over the course of a year, those that continue to use non-prescribed opioids, the source of those drugs starts to become being prescribed by more than one physician as the second most likely source. The third most likely source is being bought by a friend or a relative, and then being bought from a drug dealer starts to go up when it gets past a year. So what you can clearly see by this data is that non-prescribed opioids are often used when there's just excess pills sitting around the house, and that physicians often are taking over in the prescribing of those drugs kind of unwittingly for people that are likely using illicitly in the first place. Another really interesting way to look at this data is this one study that is published in the Journal of Obstetrics and Gynecology, the Green Journal. That's kind of the main journal for the OB world. In 2017, they looked at C-section discharges. They did phone calls over 6 academic medical centers, 720 women discharged from C-sections. They found that the median number of opioid tablets dispensed to women after the C-section was 40, but the median number of consumed tablets was 20. 95% of the people that were polled did not safely dispose of their opioids in any way. What you see is, interestingly, if you look at that blue line on the right, the more tablets people are dispensed, the more tablets they consume. people tend to use about half of their script, and no matter what, in this study. And what was also really interesting is that one would think that patients that had more medications prescribed to them had higher satisfaction scores. That actually was not shown to be true. There was no difference in satisfaction if they were prescribed 10 um, tablets of oxycodone or 100 tablets. There's also no difference in pain scores. So patients that were prescribed more pain medication didn't report better pain relief. What we did see a difference in is that patients that were prescribed more pills were more likely to request a refill later. And all that shows me is that post C-section, some women that are overprescribed opioids tend to develop some opioid dependence, and then they feel like they need this medication in the longer term. Patients that are prescribed less, they have less in their home, they have less of a risk of dependence. That also tells me that we're prescribing way too many tablets. There's millions of tablets out there from not just C-sections, all sorts of surgeries that just sit in people's homes and often get diverted and often end up fueling people's opioid use disorder in the future. So you might be thinking, is Dr. Hayes saying that this is all physicians' fault? And I think the answer to that is no, if you really dig into the data. You see that, of course, in the 90s, in the early 2000s, that's the Purdue Pharma opioid overprescribing era that's been heavily publicized in television shows like Dope Sick. We see that, yes, physicians definitely overprescribed. There was this whole pain is the fifth vital sign. Everybody is having their pain inadequately treated. Let's prescribe everyone oxycodone. And that clearly led to harm. But then in around 2008, 2010, our prescribing habits actually plateaued. Physicians started to prescribe less opioids to patients. We started to kind of become aware of the opioid epidemic. But we still see increasing deaths over that time. So I think some of it might be that patients are no longer getting safe opioids from physicians and they're going to the drug market. But there's clearly something else here at play that is leading to the rapidly increasing amount of death we see from drug overdoses. If you really look at the evidence, there clearly is something more than just physician overprescribing. What we see is three eras of drug overdose deaths. In the 90s, there was the rise in prescription opioids. Around 2010, people started to capitalize on the prescription opioids. Drug dealers kind of realized that actually heroin is a cheaper solution than the illicit market for oxycodone. And then around 2013, we see that the drug dealers realized that actually synthetic fentanyl is a way to produce much cheaper heroin than having to go to fields and grow opioid poppies and ship it across. Like you can make fentanyl in the lab, and it's so much more potent. You can much easier smuggle much larger quantities. So it starts to get synthetic opioids really start to become a thing that drastically lead to death and increases of death. Over 500,000 Americans have died of drug overdoses in the last 20 years. This is a serious problem that we're trying to fix. So again, if you look at trends, we see that prescription opioids are initially the problem and are initially the most common cause of overdose deaths. Heroin starts to take over around 2010. And then around 2013 to 2015, we really see synthetic opioids becoming increasingly in our drug supply, causing much more death and drastically increasing the harm.
So thank you for listening to me about the epidemiology of opioid use disorder. I just want to reiterate that there are a lot of patients in the United States that need help. They need treatment for their opioid use disorder. They need counseling. They need naloxone. There are people that are recreationally using substances that need education on how to safely use substances. We have a national crisis of drug overdose death, and we need physicians to step up. We need you to take this knowledge that you're learning in this training and begin to really help people with it. because people are continuing to die every year for the last 5 years. We've broken a record for the amount of drug overdose deaths. We need to start to turn that tide, and the way that we do it is we get primary care physicians like you involved in the treatment of patients with substance use disorder. Over the next 90 minutes or so, my plan is to present an approach to caring for people that use opioids via 3 different patients. We're going to cover Frank, the casual drug user, who might not have an opioid use disorder but is using drugs. Sarah, a patient with a moderate opioid use disorder, and then Tom, kind of the boss level, or the patient with more severe opioid use disorder. So our first case is Frank. Frank's a 34-year-old man that comes in for a routine physical exam. He's healthy. He's just here because his boss makes him come in to get health insurance. He's a tax lawyer. Frank admits that he occasionally uses drugs. What he tells you is that he uses oxycodone 20 to 40 milligrams at the end of a stressful day, 2 to 3 times a month. He's occasionally used cocaine when drinking with coworkers, about once a month. He buys these drugs from a friend, a trusted source. He doesn't really see this drug use as a problem. He's never overdosed. He's never had any medical complications of his drug use. He's never missed work or used at work. He's never had any legal problems, and it hasn't affected any of his family or relationships. So we have a case here of a relatively young person that is using substances, but has no discernible consequences from that use. So I guess the first question is, does Frank have a substance use disorder? And then I guess the next question is, what should we say to him about his drug use? This is certainly not healthy behavior. So how do we help him? So if you look at the DSM criteria for substance use disorder, in this case, opioid use disorder, what you have to have in order to diagnose a substance use disorder is essentially consequences. You have to have escalating use over time, use despite trying to stop, more time spent just thinking about using drugs, and it's starting to consume your life, and then craving the drugs when you're not using them. Physiologic tolerance or withdrawal is part of it, but it is not the only thing. For example, many patients on chronic opioids for chronic pain have physiologic tolerance or withdrawal, but that does not mean they have a substance use disorder. That just means that they have been taking larger quantities of opioids for a long period of time. Consequences are the most important thing to figure out to see if someone has a substance use disorder. So have they overdosed? Have they had a hazardous use, gotten themselves into social situations that are dangerous? Have they been incarcerated? Have they lost jobs? Have they gotten DUIs? Have they lost relationships? The more consequences you have from a substance use makes it more likely that you have a substance use disorder, and the more consequences you get, that defines it if it's mild, moderate, or severe. So in this case, our patient Frank actually does not have a diagnosable substance use disorder. What he has is hazardous drug use. There are quite a lot of people in the US that have hazardous drug use without diagnosable substance use disorders. Some estimates from the Substance Abuse and Mental Health Services Administration says that close to 60 million people in the US are actively using drugs. Many people that use drugs do not develop any kind of drug problem from that substance use. There's kind of a myth that people often feel, once you touch whatever drug, it will permanently consume your life. And that's just not true. Only about 20 to 30% of people that use heroin develop substance use disorders, 15 to 20% of people that use cocaine. Alcohol is 10 to 15%. Meth is 5 to 10%, and marijuana is less than 10%. So this idea that we got from Nancy Reagan or from Dare that the substance itself is what causes really significant disorders. And once you just have that first taste, just don't do drugs. It'll completely define your life. It's just not true. So abstinence-only education maybe isn't the way to go here, because there are a lot of people using drugs. They're going to use it no matter what. And we more have to focus on maybe safe use, or because these 60 million people are also at risk for all sorts of consequences. They're just not having disordered use. So why do people develop substance use disorders? Well, the answer is really clear. It's stress and trauma. So why some people can use heroin once and just say, oh, okay, that was an interesting experience, I'm never going to do it again, versus people that use it once and it defines their life, and it's something that they're never going to be able to stop using again. It has a lot to do with their life circumstances. So people that have lived terrible lives, that live with PTSD, who have significant physical, emotional, economic trauma, people with poor education and poverty whose lives are terrible in general, are a lot more prone to use substances to help cope with a stressful, traumatic life. So we need to acknowledge, kind of as a society, that addiction is a symptom of significant social inequities that we have in our society. It's not necessarily the problem itself. It's not that the drugs that are causing these problems, it's that these problems exist, and substance use is a coping mechanism. So we can still treat the substance use disorders when they exist, but also we need to recognize that there's some social inequities here that are fueling this that we can also try to address. So we know our patient Frank does not have a substance use disorder, but he is using potentially hazardous substances, correct? So I want to make a point here. Look at these drugs up here on the top of the screen. What drugs are they? Do you know from looking at them? If I'm going to take these drugs, how much should I use? What's a safe dose of them? How do I safely get these drugs into my body if I'm intent on using them? And are these full of harmful additives? Do they have tranquilizers, fentanyl, methamphetamine? Are they the drugs that I know that I'm taking? Well, unfortunately, we have an inherently unsafe drug supply. All of the above drugs are adulterated with fentanyl opioids. So we have like poorly refined heroin on the top left with fentanyl added to it. We have like the white powder, China white heroin in the middle that has fentanyl in it. And these are pressed pills that look like oxycodone, but in fact are just fentanyl. So we need to recognize that many of the overdose deaths that happen in our society are people that are overdosing that do not have diagnosable addiction. They do not have a substance use disorder. They're just using these substances to cope, to unwind, because people use drugs sometimes, and they're dying because there's adulterants and they don't know how to use them. So is there another way? Instead of telling people don't do drugs, which we know is really ineffective because people are going to use drugs, what can we tell them as physicians or healthcare providers in general to help people not die when they're ingesting psychoactive substances? One of the things that I really want you to take away from this talk is that overdose deaths are really at an all-time high. Abstinence-only drug education doesn't work. So our goal when we encounter someone with a substance use disorder should be to keep them alive. And when they are ready, offer them treatment. But there are some people that are actively using drugs that are not ready to engage in treatment. And we have a responsibility to those people to help them live just like any other patient with any other condition. So what messages can we give as clinicians to help people live? Don't mix your drugs with any other drugs. So most fatal overdoses involve several psychoactive substances that are all mixed together. Often physicians can make this worse. Sometimes these are all illicit drugs, sometimes these are prescribed medications. But your compounding risk when you mix opioids and benzos and alcohol and muscle relaxants and cocaine and stimulants and sleeping pills and antihistamines. So really, we should tell patients that, hey, if you're going to use drugs, okay, just do one drug at a time. This idea of mixing drugs actually increases your risk of death. For example, when you use cocaine as an upper, you use heroin as a downer. You can use more heroin to counteract the stimulating effects of the cocaine. That's called speedballing, but also greatly increases your risk of overdose death because you're still increasing the amount of respiratory suppressing opioids in your body despite not feeling sedated. You can always do more drugs is a really important message that we can tell people. So because we have an unsafe drug supply and you have no idea what's in that pill or powder, start with a really small dose. Wait to see how it makes you feel. If you have the desired effect with a small dose, great. If you don't have the desired effect, then take a little bit more. Take bite-sized pieces of your drugs instead of taking large quantities. Some overdose happen when people think that the drug is exactly what they think it is. They think it has the same concentration that they've used before. They'll take 3 when half of one would have done the trick. Unfortunately, people tend to die of drug overdoses alone in bedrooms or bathrooms because they're ashamed about their drug use and they don't want anyone to know. But if you're going to use drugs, the best thing to do would be to do drugs with people around. So have a friend that's with you. Have that friend have Narcan. If you're going to use an opioid, you should have a reversal agent on hand, and you can't Narcan yourself, right? So somebody has to be at a different level of intoxication than you that's able to help you if you're using. There's also another really awesome resource for people to know about if they are using alone and there's no one in their home to observe them. Use a website called neverusealone.com. That gives you a phone number. You can call them up. You can give them a pseudonym. You tell them where you are, and they talk to you while you're using your heroin or whatever other drug you're using. If you go unresponsive or if you indicate that you need help, they will call an ambulance to come and pick you up. That's a pretty robust resource. They're also trained substance use counselors, so they can help people access help if they want it. Many drug overdoses are actually hidden suicides. So I feel like I have to share that here, that we need to do a better job in general in our society at suicide prevention and recognize that opioids or other drugs are an efficient way that many people choose to end their lives. So being more cognizant of mental health and suicidal behavior can be really important. Test your drugs for fentanyl. So many people are overdosing because they think that oxycodone pill that they are taking on the weekend to unwind is oxycodone, and they know that that's a safe drug that is pharmaceutical grade, that they know what their dose is. But in fact, many of the pressed oxycodone pills out there that you can buy on the street are fentanyl, and they look identical to the old oxycodone. Many people that are just using cocaine for fun because they're out drinking on the weekend, that don't have a cocaine use disorder, are accidentally being exposed to fentanyl and dying of overdoses because it's lethal at such small doses. So if you're going to use a substance, you can get yourself fentanyl test strips. You get them online through Amazon. You can get them from many departments of public health. Most needle exchanges distribute fentanyl test strips. There's also a website called dancesafe.org that sells drug testing kits. And then, if you encounter someone that uses IV drugs, the message should be, are you using clean needles? Do you know how to get clean needles? Are you injecting safely? Do you have any infections? Just being matter of fact and helping them through their life. What people that inject drugs, what they often encounter in healthcare is someone that was just freaking out about the drug use, and then they don't offer all the help. They just tell them to stop. But really, what we should ensure if people are injecting drugs is that they're doing it in a safe manner. So make sure you're cleaning your hands with alcohol. Give them the alcohol if you have it on hand. Don't inject in your neck because you can get dissections, your groin or feet because those are very dirty. And I have seen, as a physician that cares for people with opioid use disorder, multiple pretty gnarly abscesses that people just were ashamed to show me. So if you have people that are shooting, ask them, like, could you show me where you shot lately, so I can make sure that you don't have any infections and prescribe you antibiotics if you do. So we don't let those infections fester, they don't become endocarditis or life-threatening sepsis or any of the significant problems. So next we're going to discuss a more typical case of a patient with an opioid use disorder. So our patient Sarah is a 34-year-old woman that comes in asking for help. She started using oxycodone after a fracture 10 years ago. Her physicians prescribed it for around a year and then they stopped. And she didn't stop. She started buying the drug on the street. The oxycodone got way too expensive. It can be as much as $10 a milligram. So she started buying heroin around 2 years ago. And then to use a heroin more efficiently, because she needed to save money, she started to use IV about a year ago. She now tells you she uses a gram a day, whatever that means. Sarah's scared. She recently had a friend that died of an opioid overdose. She found that person. She used to work as a nurse and lost her job. She's divorced. She doesn't have kid custody. She's been caught shoplifting and has some legal implications of that. She's just scared that she's going to die. She's seeing it all around them. And she doesn't like what her life has become. She wants to stop using. She's tried to quit cold turkey, but the withdrawal symptoms were so severe, she's always started to use again. So does Sarah have a substance use disorder? The answer to this one is obviously yes. So Sarah has had significant consequences in her life, right? She's got tolerance and withdrawal, certainly, because she's using a gram of heroin a day, which I'll tell you is around $100. That would kill someone off the street, but Sarah's built up a tolerance over time, and she's telling you her withdrawal symptoms are really severe. But also, she has had significant life consequences. She's lost a job, she's lost friends, her life she's having legal implications, and she's still craving and using the drug despite knowing that the drug has ruined her life. That is the definition of a substance use disorder. So Sarah has a life-threatening chronic disease. She didn't choose this life, but she can't really stop using drugs without help. So the cycle of drug dependence, it's important to point out that, often in the beginning, people have a normal mental state and they're using drugs to feel good, right? They reach a euphoric state. Often there's some kind of traumatic thing in their life that they're trying to escape, and they need that mellow euphoric mood to help cope. But the problem is that the body achieves homeostasis over time, and through repeated use of that drug, you downregulate receptors in your brain. What tends to happen is then you're eventually just using just to feel normal. You're not achieving those highs, but you just feel awful all the time. And if you don't use heroin, you feel even worse. You can try and stop using cold turkey, but your withdrawal symptoms are quite severe and they often make you very sick. And most people will resume drug use within a month if they do try to stop using opioids. And the thing is, often when people start using again, it's much more severe. They use more frequently, They're more dysphoric. So every episode tends to be a little bit worse. The life of someone that's using over a gram of heroin a day is they get some relief from the opioids they use. They're functional for a few hours, then they start craving, then they start having withdrawal, then they need to get money, and then find the drugs, and then use the drugs, and then the cycle starts over and over again. And it might happen, 3, 4, 5 times in a day. So people are often using between $20 and $300 a day on their opioids. And what you have to recognize is they're not just like going to a bank account and withdrawing that $300. Certainly some people are, but with chronic severe use, you run out of money. So people are selling things. They're lying. They're panhandling. They're doing sex work. They're shoplifting. They're doing some kind of crime, or they're selling drugs to get drugs. They're just involved in this horrible cycle that they don't want, they had never envisioned their life in, and they need help by a physician or a different clinician to help break this cycle. More evidence that opioid use disorder is a physiologic condition and not just some kind of moral failing or a choice is the fMRI brain studies that we see of people that use drugs. People that chronically use opioids see downregulation of the nucleus accumbens in their brain. They see less activity because there are less receptors. That is a structural explanation of why people that regularly use opioids seek out heroin or opioids to help them feel more. If they have a good day, they need that dopamine burst, so they want to use opioids. If they have a terrible day and they feel bad, they still want that dopamine burst. So their body needs additional dopamine in the nucleus accumbens, and that causes them to want to do more. At the same time, chronic opioid exposure upregulates activity in the amygdala. The amygdala is the part of your brain that controls fear. More activity there causes people to be extra anxious, to avoid all types of pain, to be fearful of the future. Many patients that are chronically on opioids will tell you that they fear withdrawal so much that they're not willing to go into it because they know it's just going to be awful, and that has a structural brain explanation. So yes, our patient Sarah does have a diagnosable substance use disorder. She's given us a lot of information about her life here. What else do you need in order to offer treatment? So addiction history is a thing that many clinicians aren't really familiar with, and it's really important. I have to stress that your primary goal in taking addiction history is not to sound like the police, right? Your primary goal is to establish a therapeutic relationship, to tell the person that you care, not to judge them, not to introduce any stigma. Remember, when you're asking questions about substance use, this is a activity that people often feel quite shameful about. So you're not the police, you're a physician, and you're going to provide overwhelming empathy as you ask these questions. So a substance use history should include: what drugs are you using? How do you use them? How much are you using? What treatments have you tried in the past? And remember, most people have tried recovery several times, and on average it takes 8 times of accessing help before people can make sustained recovery or sustained change. Why didn't previous attempts at treatment help? What happened? Like what caused that relapse? What are your triggers? So what's causing you to use currently, and how hard is it to avoid these triggers? You also want to get a good psychiatric history, because we know that because trauma is one of the root causes of addiction, you often see really significant comorbid mental health issues. So have they had traumatic experiences? Do they have PTSD? Do they have anxiety, depression, or mood disorders? Those are really important things to screen for. And then socially, can't stress this enough, but identifying what a person's support structure is like, because stopping using drugs is really difficult. So who are your allies in this process? Who's going to bring you down? Who do you live with? Do people use drugs in your home? Do you live in a place where they sell drugs on the street corner, where it's constantly being offered to you? Are you in a violent relationship and you're using as a coping mechanism, right? So in order to help someone make a significant change and stop using, you really have to identify what's going on in their social lives, and often we can make suggestions or counseling that can help various aspects of those social needs. You know, if you're living on the street, you're often using heroin just to cope with like the stress of being homeless. So helping people improve their lives also improves their substance use. Often people also do risky behavior in order to get their drugs. So are they doing sex work? Are they doing crime? Are you know, asking questions like that can also further increase their risk profile and give you other things that you can help with as a physician. So if you're asking an addiction history and asking how much someone is using on a regular basis, you're probably going to be exposed to a lot of vocabulary that you've never heard before as a clinician. So I'm going to try and help with that. So if someone says, "Doc, I use 3 bags a day." Well, what's a bag? A bag is about 30 to 50 milligrams of a substance that a bag tends to be around $10. Most of the street level heroin that you see across the US is about less than 25% purity, although it's highly variable. Some is fentanyl adulterated and can be some can be extremely pure because we have an inherently unsafe drug supply, so it's really hard to say. But they're using 30 to 50 milligrams of a substance when they say they're using a bag. What about, "Doc, I use a gram a day," or "buy a bundle"? These are common terms. What tends to happen with drugs is if you buy more, you get a discount. So if you buy a gram, that's $100, the price of 10 bags, but you actually get closer to like 12 or 13 bags worth of heroin. So you get more when you buy more. So, okay, if they're using a gram of heroin a day, well, how much morphine meal equivalents do we actually estimate they're using? So we know heroin is 3 times as potent as morphine, that it has about a 30-minute half-life, and depending on dose, it lasts for 2 to 12 hours in people. If someone says they shoot a gram a day, again, really highly variable because we have an unsafe drug supply and we don't really know the purity of the substance that people are using. But assuming 25% purity, which is like the common street value, 1 gram of heroin a day would be roughly close to 400 morphine meal equivalents, 375. But the problem is fentanyl has been introduced into our heroin, and it's really rare that people are using just pure heroin. So that potency can double or triple with even very small amounts of fentanyl in that substance, which makes it inherently more dangerous because fentanyl is a fat-soluble drug. It has additive effects, meaning it can get into the body and last for longer. And also the withdrawal symptoms can be more severe and last longer, again, because it's a fat-soluble drug and it absorbed into your body and can take longer to leave. All right, getting back to Sarah. Again, our patient with a moderate opioid use disorder. She has a disease that is treatable. How do we help her? What are her treatment options? We've gotten some more information about her. So what can we offer Sarah to treat her opioid use disorder? Well, there's really 3 different regimens that we're going to talk about here in this training. One is office-based buprenorphine therapy. So a partial agonist of the mu-opioid receptor, meaning it controls cravings and partially blocks the high of other drugs that people might be using. There's office-based naltrexone therapy, which is a complete antagonist of the opioid receptor, meaning it blocks the effect of any opioids and also controls cravings. And then methadone, which has to be administered in a federally recognized clinic that is highly regulated, is a full agonist at the opioid receptors, which again can block cravings and can blunt the high of other opioids that are administered with it. So what option of these three would be right for the patient? We're going to go into some of the details about these three treatment options. So methadone is a full agonist at the opioid receptor, which means it causes some nodding or some full agonist effects. It can cause people to look a little bit sleepy, have a mild sedative effect. It can only be offered in methadone clinics that are highly structured, that they have lots of federal regulations. In methadone clinics, they cannot prescribe any other drug other than methadone. They actually provide a lot of substance use counseling and support, but they do not prescribe anything else. Methadone has tons of drug interactions. One of the interactions I really like to highlight is that if you give someone on methadone fluconazole for a yeast infection, they can die, right? There are quite a few other ones. It can be quite sedating. It can cause QT prolongation, which can lead to torsades. So if you're prescribing people multiple psychiatric medications that also prolong QT, you have to watch out for it. Methadone maintains opioid tolerance. So even if you stop using methadone, you're less likely to overdose because it keeps you at a higher tolerance. And people tend to slowly ramp up on the dose over time. It's administered in these methadone clinics in a bottle. It's often mixed with like Kool-Aid. Has a pinkish look to it. Buprenorphine is the drug that can be prescribed in an office by a primary care physician. Because it's a partial agonist at the mu opioid receptor, it's only minimally sedating as opposed to methadone, which is moderately sedating. Most people on buprenorphine don't look tired, they just look normal. It can be administered by a primary care physician, which means the primary care physician can do all sorts of other things. They can offer psychosocial support, but they can also prescribe birth control and psychiatric medications and link them through a social worker, whatever else the patient needs. And there are no clinically significant drug interactions with buprenorphine. Sometimes people get a little bit of headaches and constipation with it, but those symptoms are relatively minor. Buprenorphine also maintains opioid tolerance like methadone. So if you stop using methadone or buprenorphine, and resume using whatever opioid you were addicted to, you're less likely to overdose because it kept your tolerance up during that period where you were on these drugs. Buprenorphine has some tricks to induction, which we're going to get into, but basically, because it's a partial agonist at the receptor, it can lead to precipitated withdrawal if you don't initiate the drug properly. And naltrexone, okay, our third option. Naltrexone is an antagonist drug. It does not have any sedation associated with it. Naltrexone for opioid use disorder is best administered in an injection form. There is a pill, but the pill is really only for alcohol use disorder. It doesn't really work for opioids. IM naltrexone can be administered in an office by a primary care physician, and just like buprenorphine, they can get all of the other services that a primary care physician can provide. Naltrexone blocks all opioids, and it also controls cravings at the same time. The side effects are relatively minor. Sometimes people will get injection site pain. It gets injected into the butt and the gluteus and the upper outer quadrant. The main problem with IM naltrexone is it's incredibly difficult to start on patients with opioid use disorder because they have to be 5 to 7 days with no opioids in their body. If you give Vivitrol to someone that does have opioids in their body, what it does is it causes precipitated withdrawal that lasts for a really long time, like as long as 2 or 3 weeks, where they're vomiting and having significant withdrawal symptoms. Vivitrol also eliminates all opioid tolerance and makes people hypersensitive to opioids. So it works great while people are on it. It blocks the effects of all opioids, it blocks cravings. But if someone happens to miss their next appointment and they don't get their shot and they get exposed to that same opioid that they used to use, they're at relatively high risk of overdose death, which I think limits its clinical utility in many patients that we know follow-up is often an issue in patients that use substances. So why should you prescribe buprenorphine or naltrexone in a primary care clinic instead of referring patients to a specialist or referring them to a methadone clinic? Well, primary care clinicians are amazing and can do all of the things, and methadone clinics have a very limited scope. Of course, we can prescribe the bupe, but we can also do preventative medicine, we can screen for intermittent partner violence, we can treat anxiety or depression or PTSD, we can prescribe birth control. We know the rate of unintended pregnancy is quite high in this population. We can, provide pediatric services, we can treat Hep C, HIV, COPD, blood pressure, diabetes, lipids like any other primary care physician or patient. We can treat their mood disorders. We can provide comprehensive wraparound services. And this is what a patient really needs when they're in early recovery. So there's a strong argument to do this type of service in a primary care setting. Addiction specialists, addiction psychiatrists, often really don't do any of this additional stuff. They're focusing on just the addiction, and they're missing a huge part of that patient's care. And it's true, often patients don't want to access multiple different doctors for multiple different things. They want a one-stop shop. And we can do that in a primary care setting if you prescribe buprenorphine. Patients usually won't get that additional care unless we're the ones doing it. So it's important to point out that office-based opioid treatment reduces all-cause mortality, not just opioid overdose mortality. Meaning, we're helping prevent some lung cancer and some heart attacks and deaths from high-risk pregnancies, as well as reducing the risk of overdose, because we're doing the primary care job alongside the addiction job. So you might still be thinking, I don't know, this all sounds really complicated. Methadone clinics are set up for this type of thing. I'm just going to refer patients to a methadone clinic. You have to think about it from a patient's perspective. Methadone clinics definitely have a place and are definitely helpful for many people. But what they do is they require a patient to come every day to that clinic and wait in line for between 15 and 90 minutes to get their dose, which they drink in front of a window. After earning trust and being in recovery for a sustained period of time, they might get some take-home bottles, but people are never getting more than a week of take-home bottles at any given time. They were frequently going back to that window. Methadone causes significant side effects: QT prolongation, sedation, drug interactions, osteoporosis. And again, in a methadone clinic, they can't provide any of the comprehensive services that a primary care physician can provide. It's also quite common that drug dealers will prey on patients outside of methadone clinics. They know, like, hey, here's a large patient population that uses opioids. Some of them even have methadone to trade. So I'm going to kind of post outside of this clinic and try and poach some of their patients. Methadone clinics are often placed in urban centers, but we know that the opioid crisis is everywhere in the US. It's also a rural crisis. So there are many patients that don't have access or would have to drive hours to get to a methadone clinic instead of 10 minutes to their local family physician or an internal medicine doc. I'm not trying to say that methadone doesn't have a place. They do get people into individual and group substance use counseling quite easily. The structure of going to a window and dosing in front of someone can be really helpful, particularly if people have failed office-based treatment. The retention rates in a methadone clinic are often quite high, so people that go end up going back. So that means they're doing something right. And buprenorphine and methadone have roughly equivalent efficacy and retention rates, which means that they are both completely viable treatments. It's just about finding what's right for that person. So you might be thinking, oh, naltrexone is a full antagonist that blocks all cravings. Why don't I just give everybody naltrexone? They don't have to worry about them using drugs ever. I'm just going to block their cravings, and this is like the vaccine against opioids. It sounds like the perfect drug. Well, really the problem here is that it's an extremely difficult induction, like I said before. You have to be 5 to 7 days opioid free before you give your first Vivitrol shot. And the problem there is that many patients are using opioids on a daily basis. And to get them to 5 to 7 days with no opioids in their body is an extremely long time for them. They're going to be really sick. They're going to be throwing up. They're going to be violently ill. They're going to be having nausea, anxiety, diarrhea, panic attacks, lacrimation. And many patients will try to do the Vivitrol shot, but will just not be able to make it, right? They won't be able to abstain from opioids for long enough. And unfortunately, during that period of time where they're washing out drugs out of their system, they're also losing their tolerance. So there's a worry that they will overdose before they even get their Vivitrol shot. It works great when it's in someone's body, but then the problem is this drug wears off, and then patients are actually more likely to overdose. They're hypersensitive to opioids once the drug wears off. So Vivitrol does have significant advantages. That's a monthly drug. It has high treatment efficacy. Once people are on it, it has equivalent rates of abstinence and retention and treatment as buprenorphine and methadone. However, that's a big caveat. It's once people are on it. It's getting them on it that is the biggest challenge. And because it's administered in an office by a primary care physician, you still get all those benefits of seeing a primary care physician on a regular basis. So all this leaves us with buprenorphine. It is often the best choice for people with opioid use disorder that are seeking our help. The one thing you need to know about buprenorphine before you can safely prescribe it is that it can cause a syndrome called precipitated withdrawal. What precipitated withdrawal means is that a patient has opioids in their system, full agonists in their system. If they take buprenorphine, because buprenorphine has a high affinity for the opioid receptors, but only 60 or 50% receptor activity, so the buprenorphine comes in, kicks off the other full agonists on the receptors, and is suddenly only activating them at a fraction of the amount they were activated. So that process of that rapid change from full receptor activity to partial activity causes precipitated withdrawal. And withdrawal is awful. It can cause, crying, piloerection, hypervigilance, yawning, body aches, headaches, abdominal cramping, diarrhea, panic attacks, nausea, vomiting, diarrhea. It's just miserable. So you have to dose this drug properly, and once you learn how to use it, you can safely get people past this process, but you just need to know the consequences. So the main thing you just need to know is don't give full strength buprenorphine to a patient if their COWS is less than 12. So COWS is a clinical opioid withdrawal scale. People need to take buprenorphine when they're in withdrawal, or if they're completely opioid free and have been and they're not in withdrawal at all, then they can just start with really low doses of buprenorphine and work their way up, like 2 milligrams, for example, twice a day. But if someone is switching directly from heroin to buprenorphine, they must wait until they're in moderate to severe withdrawal, which is defined in the COWS scale, the clinical opioid withdrawal scale, as greater than 12. So how does someone take their bupe? Well, this is a sublingual med that goes under the tongue. Bupe has extensive first-pass metabolism, which means if you swallow the buprenorphine, if you swallow the spit, if you put it under your tongue and then chase it with a whole bunch of water or coffee or soda, then you're not getting the full effect of the drug because it must be absorbed through the tongue. It also tastes kind of gross. The most common form that people see, the Suboxone, has a really strong citrusy tang taste with a bitter aftertaste, and there's a minty version called Zubsolv. But a very common thing I'll say as someone that prescribes a lot of this drug is that people will take it wrong. They won't wait the full 10 minutes. It's supposed to go under your tongue. You're not supposed to swallow, spit, talk, eat, or smoke. And then after 10 minutes, you can either spit or swallow the saliva that's accumulated in your mouth, and you should be good to go. The manufacturer also warns people that you're not supposed to brush your teeth immediately after using buprenorphine because it can soften the enamel of your teeth and lead to dental disease. So you have to wait at least 30 minutes to brush your teeth as well. Okay, so how do you start someone on buprenorphine? Well, there's really two different methods. There's the traditional induction and the microinduction. I'm going to go over both. So right here you see the traditional bupe induction. So a patient should wait until they're in moderate withdrawal, which is defined as, you could use the clinical opioid withdrawal scale or the COWS scale, greater than 12. Then that person should take 2 to 4 milligrams of buprenorphine sublingually. They should wait a while, see if they tolerate that dose. Do they get sick? If they took a small dose, then they won't get very sick. If they took a huge dose, they'll get sicker. On the first day, patients should take small additional doses of bupe. So they can take 2 or 4 milligram doses intermittently over the course of day 1. Their max dose should be 8 to 12 milligrams. On day 2, they take everything they took on day 1 and just take it all in the morning. And then in the afternoon, they can do the same thing by taking 2 or 4 milligram small doses. And then people should be really, by the end of day 2, feeling much better and induced on this drug. A typical dose is 8 milligrams twice a day, so 16 milligrams a day. Some patients go up to 24 milligrams, but I usually don't go up to 24 milligrams until I see them or after a few days, unless someone's using larger quantities, which we'll get into. So there's another method of bupe induction called microinduction that is appropriate for people that are using large quantities of fentanyl adulterated heroin, or if for some reason someone is on other forms of opioids and can't stop them, like if someone's in the post-op period and they have to be prescribed oxycodone, but you want to get them on buprenorphine at the same time, like how do you do that without making them go in withdrawal? Well, with bupe microinduction, you just give tiny amounts of the bupe and you slowly ramp it up over time. And that way you're not kicking all of the drug off the receptors at once, and people tend to do really well. So with bupe microinduction, patients get a fourth of a 2 milligram film every 4 to 6 hours for the first day. So that's literally 0.5 milligrams that they're using every 4 to 6 hours for day 1. Day 2, they should take a half of a 2 milligram film every 4 to 6 hours. So that's, they're taking 1 milligram every 4 to 6 hours over the course of day 2. Day 3, they can take a full 2 milligram film every 4 to 6 hours. So that's a daily dose of 8 to 12 milligrams. They're starting to ramp up. And day 4, they can go on to their regular schedule of taking 8 milligrams twice a day or 4 milligrams 3 times a day. And then after that, you can titrate their dose to effect. Most inductions can safely take place at home. People have been administering opioids on their own for long periods, often most of their lives. So the idea that they need to do it in an office supervised by a physician is just outdated. Sometimes people with complex conditions like pregnancy or really high dose opioid use or really intense generalized anxiety or panic disorder, they'll require inpatient stays to start these regimens, but it's really rare. Most of the time, you can see someone in the office, talk them through these induction strategies, and then send them home to do it on their own, and then doing close follow-up within 3 to 7 days after their visit. A question I frequently get when I'm doing induction is, how much do I think that this person needs? How much buprenorphine is this person going to require? Well, if someone is not in withdrawal, but they still want bupe in order to help control their symptoms, they should start with low dose. So buprenorphine 2 milligrams twice a day or 3 times a day, 4 to 6 milligrams a day total. And then you can just titrate to effect. You can just slowly increase the dose based on how they're experiencing cravings or pain, if that's what you're using it for. Someone has a moderate opioid use disorder and they're using, less than a gram of heroin, less than 100 milligrams of oxy a day, then they're probably going to be okay at a little bit more of a moderate dose of bupe, which is 8 milligrams twice a day or 16 milligrams total. Some people do choose to take 2 films at once, so 16 milligrams once a day, but I would say most people prefer to split their dose into 2 different films at different times a day. Many people will report that the bupe will wear off over the course of the day, so they need that split dosing. Someone has a severe opioid use disorder that's using large quantities, so over a gram of heroin a day or over 100 milligrams of oxycodone. These are people that are probably going to need 24 milligrams to start. So they would take 8 milligrams 3 times a day, or maybe 16 milligrams in the morning and 8 milligrams in the evening. Or they actually have a 12 milligram formulation, so you can prescribe 12 milligrams twice a day. People with severe opioid use disorder would probably be better served by taking Sublocade, which is that once a month depot Suboxone, which we're going to get into here in the future. This was all really complicated, so it is important to point out that there's a really good app that's available for free that can help people figure out when they can take their first dose of buprenorphine, that does the clinical opioid withdrawal scale based on their subjective findings. So this buprenorphine home induction app is on all the app stores and can be quite helpful in helping people figure out how to navigate their own home induction on their own terms. So when someone comes to you to start their buprenorphine, they're starting an induction visit, what are the goals? What should the patient leave with after this initial encounter? One is support, right? Someone's come to you and they want to stop using it. They're making a massive behavior change. They're treating a very serious chronic disease. So just like how you would encourage someone that you're just starting insulin on for the first time as a diabetic, you need to really offer lots and lots of support. You should instruct them that the buprenorphine is going to remove 90% of their withdrawal feelings. But in the first week, it's going to be normal to have some cravings. You're going to have some desire to use and some cravings. You're going to have mild symptoms, though that 10% is going to start to go away over time. Again, what we talked about in the last slide is methods to avoid precipitated withdrawal. The patient should be able to teach back the induction method that we just discussed, so that they're going to be able to take their meds for the first time and not make themselves sicker. The goal in the induction visit is to really identify the lowest possible dose of buprenorphine. If 8 milligrams once a day does it and the person doesn't need any more, that's fine. Great for them. They're on a lower dose. If someone needs 24 or 32 milligrams because they're really heavy chronic users, that's also fine. Just whatever the lowest effective dose is for them. Most people in early recovery will experience mild headaches, insomnia, and nausea, and some anxiety. That kind of comes with this massive behavior change plus like all of the chemical hooks that come with opioids. So You can prescribe medications to help with those mild withdrawal symptoms. So you can give them trazodone for sleep, hydroxyzine for anxiety or insomnia or sleep. Mirtazapine is a drug I really like because it helps often people who are underweight that are heavily using drugs, so it can really help with the insomnia and the anxiety. Melatonin can also really be helpful. Short interval follow-up, right? When you start someone on bup, you really want to see them within a week to make sure that they took the drug appropriately, that things are going well, to titrate their dose, to troubleshoot any issues that may have come up. You also have to acknowledge, remember the first part of my talk where we talked about safe drug use, that this change is not immediate. People are likely to still use some drugs. So at the same time, when you're doing all of this counseling on how to start buprenorphine, you also should counsel them about safe drug use and use all those safe drug use tips that I talked about before. Literally, I don't care if you're prescribing bup or not. I don't care what specialty you're in. Literally 100% of patients with an opioid use disorder should leave every clinician visit with a prescription for Narcan. There's no reason why they shouldn't be prescribed it. It doesn't increase risky behavior. It doesn't increase risk of overdose. It has no abuse potential. Everybody should have some naloxone if they have an opioid use disorder. And remember, you can't Narcan yourself, so you should talk to them about giving it to a friend or somebody that knows that they have an opioid use disorder that can check in on them if they are using. All right, going back to our case, we have Sarah here. Sarah is 34 years old. Again, she's got a moderate opioid use disorder. She's had really significant life consequences. And when she comes to see you, she's in withdrawal. So you say, okay, great. Well, I'm going to prescribe these drugs to the local pharmacy. You're going to go pick them up, and we're going to do a traditional home induction. Remember, that is, I'm going to prescribe you an 8 milligram film. I'm going to have you take that 8 milligram film. You're going to cut it in half. You're going to take half the film when your COW score is greater than 12, when you're in moderate withdrawal. You're going to wait an hour or so to see how you feel with that half of film. If you're feeling okay, you can take the other half. And on day one, just take one film. If you feel like you absolutely have to take more, you can take an additional half film on day one. But most people are fine with just 8 milligrams on day one. On day two, take that full strip in the morning, and then take a full strip in the evening. And then you're induced on Suboxone. So what I typically do is I prescribe people 14 films or 7-day duration, and I see them the next week. And I have them return to the clinic in 7 days. A common thing that often happens, particularly in Wisconsin where I practice, is the pharmacies are really rude to the patient, or we can prescribe the drug without putting the diagnosis code. So here in Wisconsin, buprenorphine is diagnosis code restricted, which means you have to send it over with a code called F11.20, opioid dependence or opioid use disorder, in order for the pharmacy to consider filling the drug. You also have to have a DEAX number. Remember, you don't need to take the full Suboxone 8-hour waiver training course in order to get that DEAX number. All you have to do is go on to the buprenorphine notice of intent to prescribe website and quickly get that number. You can it's just your regular DEA number with an X instead of the first letter. So our patient Sarah returns after induction in a week. She took the meds exactly as prescribed. She's out now. She admits that she did still have some cravings in that first week, and she used heroin 3 times. She also had some pretty intense anxiety on the second day of her induction, and she took a Xanax that her friend offered her. So, okay, we have a patient with moderate to severe opioid use disorder that we prescribed bup to, but she's still using heroin, and she's now using other drugs too. She used the street Xanax. So, what do we do? Is she failing treatment? What you should do is you should really celebrate that this patient is doing fantastic. If you think about it, that office-based buprenorphine treatment is not a miracle cure. No person ever changes their behavior instantly after one episode of counseling with a clinician, no matter how good that clinician is. Incremental change is the reality here. And this patient went from using several times a day to 3 times in a week. That's a 90% reduction of their total drug use. That's a really remarkable improvement. And she's adherent to her meds. She's doing exactly as you prescribe. So again, that's great. If a person living with diabetes cut out 90% of their carbs after their first visit with a nutritionist or a clinician, you would be celebrating. You'd be really excited. You wouldn't be yelling at them for the 10% of carbs that they are eating. It should be the exact same treatment approach for opioid use disorder. The main goal in caring for people with opioid use disorder in a primary care setting is to keep them in treatment, retain them, and they will get better over time. So what the evidence says is that the longer someone is retained in treatment for their substance use disorder, the more likely they are to develop an opioid negative urine. That, people aren't just going to instantly change and instantly give up all their opioids all at once. We need to keep people alive. So you get them on the buprenorphine because it increases their tolerance and make sure that they're taking it. But we should also do those harm reduction things that I talked about before. Talk about safe drug use, provide clean needles if they're injecting, provide Narcan at every single visit and make sure that they have it and people know that they have it. So after your initial induction visit, every visit after that is really just an opportunity to use motivational interviewing and continue them on their medication. Examples of that: checking in with the patient, seeing how they're doing. When's the last time they used? If they used recently, why do you use recently? What were the circumstances? What steps can you take to prevent those circumstances? If they haven't used recently, congratulate them and help them see how their life might be different because they're not using, or what barriers they might experience along the way. Like, it seems like you're doing well now. Is there anything that could interrupt that? Talk to your patient about cravings and withdrawal or drug dreams. If they're having any of those things, then consider slightly increasing in an increment of 4 to 8 milligrams their buprenorphine dose. It's standard practice to confirm your history with a urine toxicology. That doesn't necessarily mean you need to solely rely on the urine toxicology. You take a good patient-centered history, but then use a point of care test to confirm that history to make sure the patient is being completely honest. And you can send out these confirmatory tests when there's discrepancies between what the patient is saying and what the test is showing. Contingency management is a key part of maintenance visits as well. Initially, patients tend to show up very frequently, once a week, once every 2 weeks, while they're stabilizing. When patients earn some trust, when they're taking their medications, they're no longer regularly using drugs, then we tend to space their visits out to once a month, once every 3 months in certain circumstances when people have been in recovery for a long period of time. So you have this graduated trust, and if people start using again, then you shorten the visits down again. That's a good example of contingency management with frequency of doctor's visits. A bonus question that you should really consider asking for every patient is, do you have Narcan available? And do people around you know where that Narcan is? You can't Narcan yourself if you're overdosing. And the truth is, many people die alone when they're in recovery because they're afraid to share with others that they're using again. So it's just normalizing that patients should take a safety step with their loved ones or the people that they live with and let other people know where that Narcan is and make sure it's always in stock. Of course, after the initial maintenance visit, really it's important to stress that you should be doing basic primary care at all of these visits. Try not to just focus on addiction. Work on smoking cessation. work on diagnosis or treatment of STIs, treat them for COPD or hypertension or hyperlipidemia, or get them on birth control, or talk about their mood disorder. There's so much more to handle in the addiction medicine visit than just the addiction. And unfortunately, what can happen is you can just hyper focus on just that addiction component. But if we're doing this in a primary care setting, we can provide all of these wonderful wraparound services. And in fact, many of these other things will improve outcomes even faster than just adhering to Sublocade or just focusing on the addiction. So don't forget all of the other primary care things in these visits. They're very important. The question we frequently get, well, we just covered office-based opioid treatment, correct? You get somebody on buprenorphine. Well, what about getting people in with group therapy or individual therapy? What about those psychosocial treatments? Well, of course, you should treat mood disorders and provide counseling. It can be a really important component of treating addiction medicine, but there's no evidence that participation in counseling should be a prerequisite to receiving buprenorphine, because medication alone has been shown to be effective treatment for 80 to 90% of patients. So you shouldn't require someone to do group therapy or individual counseling. You can recommend it as a really helpful adjunct, but the meds alone can be really effective in many. So if you're going to recommend psychosocial treatment, what should you recommend? Well, there's a whole bunch of different options. In the office, of course, primary care physicians can do things like motivational interviewing. We can either do cognitive behavioral therapy ourselves or refer to psychotherapy colleagues. Family support and therapy. Often family members don't really know how to deal with patients with addiction. So coaching family on how to interact with patients is really key. Also social work. It's hard to not use drugs if you're living on the street, if you're in incredibly stressful situations. Um, Often drug use is a coping skill. So helping people with that mental health and social support can really significantly impact their substance use disorders. The formal psychosocial treatments that you should consider offering are things like Narcotics Anonymous or Smart Recovery. Narcotics Anonymous is kind of the traditional 12-step program. Smart Recovery is based on Buddhist principles, and it doesn't require people pursue a higher power. So for atheist patients or people that are turned off by the kind of religiosity of Narcotics Anonymous, Smart Recovery would be a good referral for them. There's 3 different levels of care that you should know about. There's intense outpatient programs. These last anywhere for 3 or 4 hours where they're doing intense group therapy work. There's partial hospitalization programs that last pretty much the whole day. These might last 6 to 8 hours where they're doing really intense group and individual therapy work, but then they go home and sleep in their own home. And then there's inpatient or residential programs. There's short, like detox stays, where you're in an inpatient program for maybe 7 days. And then there's residential programs where you're living in a program for 30 to 90 days, getting treatment every single day. That's kind of the highest level of need, and this the most difficult to acquire, obviously, because it requires quite a lot of resources. One thing that I highly recommend that we do as physicians when we're recommending people for psychosocial treatment is think about other things to do with your time. Many people that regularly use drugs will tell you that it consumes their whole life. They don't have hobbies, they don't have work, they don't have anything to do. So when they stop using drugs, they often get bored, and they'll cite boredom as a trigger for continuing to use. So helping motivate a patient to really like engage in parenting or gardening or getting a job or getting a pet, like do something that really mm, takes up a large part of your time, and that can be a really significant treatment. Okay. So coming back to the case, our patient Sarah gives us a urine, and the urine toxicology tests are shown here. Her test is positive for opiates. There's fentanyl in her urine, and there's buprenorphine in her urine. Well, we did a reflex confirmatory test in this case. Now, you don't always need to do that, but in this case, we did. Her buprenorphine screen is positive for norbuprenorphine and buprenorphine gluconate. These are both metabolites of buprenorphine, and it has almost no unmetabolized drug in it. What does that tell me? Well, that tells me that this patient took buprenorphine and it's being metabolized in her system. The metabolites are higher than the unmetabolized drug. That's good news. She's been on the medication long term enough to build up significant stores of metabolites. So this is an example of a really positive drug screen. Of course, she did use some heroin, but she endorsed that in her story. But more importantly, she is taking the buprenorphine, and studies show that if you keep them on buprenorphine long term, the heroin use will gradually taper off. So this is consistent with her story, and we're happy with it. So our patient asks us, Doc, I'm doing really well. I'm not using heroin anymore. I'm taking buprenorphine 8 milligrams twice a day. I feel really good. I'm going to go back to school. I'm reaching out to family members. My life is starting to get better. How long should I stay on this drug? I'm not using anymore. Should I stay on bup for the long term, or should I just taper off now that I'm not using? Well, there's a lot of evidence on this particular question. Basically, as far out as they study buprenorphine use, there's really strong evidence that people should stay on it and that outcomes tend to be worse when it is tapered off. So when bup is tapered off, there's relatively high rates of relapse. There's relatively high rates of overdose and opioid prescribing. So in general, the standard is buprenorphine maintenance therapy for a very long period of time. The national standard, what I tell everyone is that I recommend that you stay on this medication for at least 6 months before you even talk about any kind of taper. And honestly, many people should be on this medication long term. So what are my criteria for recommending somebody stop? Is someone psychologically stable? Is their life relatively low stress or stress-free? Do they have stable housing? Are they have a regular source of income? Do they have good family and social support? Are they not in a situation where they're regularly exposed to drugs? Like no one's showing up in their house with heroin, or no one's selling heroin on the street corner in front of their home. Well, if they meet all of those criteria, then they're ready for a taper. If they don't meet those criteria, then do not attempt a taper. And it's just important to recognize that some people won't meet those pretty strict criteria. It is okay to stay on buprenorphine therapy for life. And honestly, the outcomes are much better on every study that has been done on these patients when they're maintained on medication versus taken off. Oh, our patient just comes back. She's doing really well, but now she has a positive pregnancy test. She says, "Oh no, doc, what do I do now? Now I'm pregnant on buprenorphine." Well, there's a couple things to consider here. One is that we probably should have had her on birth control from the start. The rate of unintended pregnancy is quite high in women with opioid use disorder. It's quite high in general, like 50% of all pregnancies are unintended, but in women with opioid use disorder, that number is closer to 80%. The American College of Obstetrics and Gynecology recommends that all women with opioid use disorder be considered for long-acting reversible contraception, something like the Nexplanon in the arm or an IUD. It's also important to counsel people that when they start buprenorphine, it's likely they're going to get a fertility bump. The chronic stress of regular heroin use and the anti-androgen effects can suppress fertility. But so people maybe have been sexually active for years and they've not gotten pregnant, and they'll think that they're infertile. But once their life starts to really stabilize and they start sleeping and eating and taking the buprenorphine regularly, those stressful effects on the endocrine system kind of go away, and people experience this fertility burst. So anyway, our patient is pregnant. What do we do? So what you should do when you have a pregnant patient with opioid use disorder is continue medication-assisted treatment. Technically, all 3 forms of medication-assisted treatment are safe in pregnancy with a bit of caveats. So buprenorphine, specifically buprenorphine naloxone, is considered category C in pregnancy. That's because there's some question about the safety of naloxone in pregnancy. Now, that's kind of an old recommendation. There have been multiple studies showing that naloxone is safe in pregnancy, studies with hundreds of patients. So my regular practice is to just continue buprenorphine naloxone throughout the pregnancy. Some physicians are a little bit nervous about the naloxone and they choose to prescribe the buprenorphine mono product, which is called Subutex. That's buprenorphine without any naloxone in it. Naltrexone has also been shown to be safe in pregnancy. If you prescribe it, most docs will prescribe the oral version of naltrexone instead of IM naltrexone, because if there's a complication with pregnancy and she needs anesthesia or a C-section, then the surgery can be quite difficult to accomplish if you have a complete opioid antagonist on board. Methadone is the previous gold standard for maintenance medication in pregnancy. We know it's highly effective and it's been the best. It's honestly the best studied. However, there's relatively recent evidence from 2010, so it's not that recent, that buprenorphine has really significantly better fetal effects. So, famous study known as the Mother study, they looked at moms on methadone versus moms on buprenorphine, and they looked at the fetal effects. Well, babies born to moms on buprenorphine had less neonatal abstinence syndrome, had a shorter length of stay in the hospital, needed less medication, and had shorter neonatal abstinence syndrome treatment. So the evidence is pretty clear that if you're comparing buprenorphine versus methadone in pregnancy, that buprenorphine is significantly better. So what about breastfeeding? Are these meds safe to breastfeed on? The answer is definitely yes. And in fact, breastfeeding should really be encouraged in the newborn period in this situation, because there's a little bit of buprenorphine in the milk or a little bit of methadone in the milk, and that can actually help blunt the effects of neonatal abstinence syndrome. You should warn moms, however, that if they abruptly stop breastfeeding at any point, their infant can experience the delayed neonatal abstinence syndrome. So like say someone is exclusively breastfeeding for 3 months and they just decide to abruptly stop, then they could get this abstinence syndrome at 3 months instead of right away after birth. So we warn moms to just gradually taper the breast milk over time if that's what they choose to do. One thing I do counsel my moms with opioid use disorder, however, is that if they begin using heroin or oxycodone or any other opioid, they really should stop breastfeeding, because those drugs, those opioids, are present in large quantities in breast milk and can lead to neonatal SIDS, sudden infant death syndrome, or kind of overdoses in the infant. This is a whole nother talk, but one thing I'm a big proponent of is talking about Eat, Sleep, Console. It's a more infant and mother-centered approach to treating babies with neonatal abstinence syndrome. Most babies born to moms on bup will experience some mild neonatal abstinence syndrome, but if you use the Eat, Sleep, Console approach, if you use a more patient-centered approach, most of these babies do not need medication and they can leave with the adequate maternal support. Patients will often ask, well, doc, I have my baby and I want to live happily ever after, and I don't think I need this medication anymore. I significantly push back against that notion. What I tell moms that I deliver on opioid use disorder is that the rates of relapse and overdose are highest in the 7 to 12 month range after giving birth. So that tells me that women with opioid use disorder should be on buprenorphine therapy or any kind of medication-assisted treatment for at least 1 year following the birth of their infant. And I think this makes sense. Caring for a newborn is stressful. They're up all night. It's a financial stressor. You don't get enough sleep. Um, it's a drastic change in your life. They're extremely demanding. They don't know that they're extremely demanding. So keeping moms on buprenorphine to help prevent, if they do have a relapse, help prevent an overdose is a significantly important step. We know that on pharmacotherapy, overdose events are significantly less common. Okay, our patient Sarah lives happily ever after with her baby. We regularly follow her as her primary care doctor. She weans down her buprenorphine to 12 milligrams a day. She has a job, stable housing, her child's healthy. She decides that she's just going to stay on 12 milligrams of buprenorphine every day because she doesn't want to risk going off of it. She feels totally normal on that med. This, I think, is a extremely positive outcome. And, you know, the rockiness of this case is kind of common. I wanted to show you that people will sometimes use other drugs. They'll sometimes get pregnant. There will be some bumps along the way, but if you stick with them and you work with them, you get to see this dramatic transformation, and you really get to help someone recover from their addiction. These cases are extremely common, and I would say the majority of patients that engage in buprenorphine treatment will have a significantly positive outcome. There are patients that are more challenging, and we're going to cover that in the next case. Right. So this is boss level. This is our most challenging patient here. Our patient Tom is a 42-year-old man who comes to you for help with his opioid addiction. He started using 15 years ago, and he was only able to stop using when he was in prison and couldn't get heroin. He's overdosed multiple times. EMS has actually been to his house multiple times in a single day. He's coming in because he doesn't want to go back to prison and he's really afraid that he's going to die. He also lives with a girlfriend that uses heroin and isn't interested in stopping. He uses up to 2 grams a day, so as much money as he can get as much heroin as he can get his hands on. He is having a lot of trouble injecting because he's scarred up literally all of his veins. Now is mostly using his jugular vein, which is inherently unsafe. He's been admitted for endocarditis in the past. And when he was in the hospital, he stayed for the whole treatment because he was given a combination of Ativan and Suboxone. He's tried methadone. He's tried detox. He's been engaged in treatment multiple times. Nothing has ever really worked. He has a significant medical history of physical and sexual trauma from abusive parents. He's lived a violent and abusive life because he's worked as a drug dealer. He also has chronic back and leg pain because he's had a gunshot wound. So this is a more difficult case than Sarah. This is someone that has really significant trauma, someone that has a very severe substance use disorder, multiple serious consequences. It seems like it's consumed his entire life. A case like this can be challenging to take on, but I want to reassure you that this is someone that we can help if given the proper time and the proper training. So we decided to give Tom a try, and we're going to give him on Suboxone because he's using significant amounts of heroin. We're going to just get him up to 24 milligrams right away. We're going to get him up on the higher end of the dosing spectrum of Suboxone. And we're planning to do that over 3 days. So I'm going to give him a 5-day supply, so 15 8-milligram films. Have him take 4 milligrams or half of a film when he's in moderate withdrawal. Wait an hour, take another half of a film.
On day one, I just want them to take 8 milligrams. On day two, I want them to take 8 milligrams in the morning and then 8 milligrams in the evening. And on day three, I want them to take 8 milligrams 3 times a day. This is a good plan. It's a relatively quick induction, but as long as he's in moderate withdrawal first, this should work. Oh, so we send him out with these meds. On day two after induction, the girlfriend calls you and he took a lot of Suboxone all at once, and he's having a panic attack. He's vomiting. He's having diarrhea. He's very ill. So they call you doc, like, what has this done to me? Am I gonna die? What should I do? So this is a case of precipitated withdrawal. He instantly got thrown into withdrawal because he probably wasn't in withdrawal significantly or had recently used heroin, and he took Suboxone anyway, and a relatively high dose. So there's two ways to deal with precipitated withdrawal, which, if you're prescribing buprenorphine, I guarantee this is going to happen to at least to somebody that you're prescribing to. This is just part of the job. So strategy one is use comfort meds and then attempt withdrawal and buprenorphine treatment on another day. So give them a couple days of Zofran, hydroxyzine, dicyclamine, there was bentyl, clonidine for all the symptomatic withdrawal. This is significant polypharmacy, and you need to be a realist. Like, if you go to this approach, they're going to resume using heroin, but they also might use some of these medications to make them feel better. It's very rare that someone is going to not use heroin during that period. Option two is you tell the patient to just take more buprenorphine. So if they took another 8 milligrams, that's going to significantly blunt the withdrawal syndrome, and they're going to feel much better pretty much immediately. This is kind of getting at what's called a high dose induction. In fact, it's been shown to be safe for patients to take repeated doses of 8 milligrams. Up to 64 milligrams in a sitting is actually safe and has been studied in large trials. It does not cause respiratory suppression. It does not lead to a risk of overdose. But what I tend to tell people if they're having precipitated withdrawal is take another Suboxone. This takes communication skills because this person is vomiting, they have diarrhea, they're having a panic attack from the first dose of the medication, and you want them to take more? Like, are you kidding me, doc? But if you can get them to do it, this is definitely the safest way to go. And it will make them feel better, and it'll get them on the beep faster. And then, what you're basically trying to prevent them from doing is going and using large quantities of heroin to make themselves feel better, because that is what they've always done when they've been in withdrawal like this. And the risk is that they're going to use too much heroin because they feel so awful that they would overdose and die. So you want them to pick buprenorphine or the comfort med strategy if you're not comfortable with more. So our patient Tom, he's starting to feel better after this precipitated withdrawal. And he admits, yeah, he didn't at all follow the induction instructions. So how do we get him on Suboxone? Well, there's a couple different ways. You could do an office-based induction. So I've done this for patients that really struggled with following instructions and need that continual support. So what I do is I prescribe them medication, so like buprenorphine or Suboxone. I have them come to clinic and sit in my clinic, and I regularly do the COWS scale on them about every hour or 2 hours. And when their COWS scale is safely greater than 12, I myself give them 2 milligrams, which is a fourth of an 8 milligram strip. And then I'll observe them for another 30 minutes on the 2 milligrams, and I'll give them another 2 milligrams. So at this point, they've taken up to half of an 8 milligram strip. So now they're safely on a low dose of buprenorphine. I'll give them the other half, and I'll say, okay, go home and wait as long as you can until it's evening, and then take that other 4 milligrams. And then they can, on day 2, take 8 milligrams twice a day, and day 3, 8 milligrams 3 times a day. The other thing we could do is something called a buprenorphine microinduction. Remember, we covered that earlier in this talk. The interesting thing about a bupe microinduction is they can actually continue to use heroin during this process, and it's not going to precipitate withdrawal. You could say, you've been using, just try and cut down on your use. You're going to have less cravings. So with the microinduction, remember, we give them a quarter of a 2 milligram film every 4 hours for day 1, and then half of a 2 milligram film every 4 hours for day 2, and then 2 milligrams every 4 hours for day 3, and then 4 milligrams 3 times a day, or 8 milligrams twice a day for day 4, and then 8 milligrams 3 times a day for day 5. So this is complicated. Often patients have trouble following these instructions. This is very safe and easy to do in a hospital-based setting, but in the clinic, you have to make sure that people teach back, write all these instructions down, explain the consequences that they could precipitate withdrawal if they're doing this. And, this is also a safe way to get people onto buprenorphine if they are actively using other opioids, like say, for example, if they're on methadone or if they're on oxycodone for some kind of orthopedic injury. This is another way to get people onto buprenorphine safely. So Tom follows up again in clinic several times, once a week for the next 5 weeks. He reports that he's taken his Suboxone 24 milligrams or 8 milligrams 3 times a day, and he's doing great, doc. It's really helping. He endorses that, yes, he uses heroin occasionally, but he's using much, much less. But unfortunately, his urine results over the last 5 weeks tell a bit of a different story. What we see is, yes, his buprenorphine screen has been positive all 5 of those times, so that seems like that's a positive result. We see him intermittently positive for cannabis, for cocaine, for opiates, and for amphetamines. So we know that Tom is using multiple different substances, and that might affect the safety of his treatment. So we kind of have to decide, what should we do? Should we keep prescribing him buprenorphine, or should we refer him out? What do you do when patients are using multiple other drugs when they're trying to stop using opioids? Thankfully, there's some evidence-based responses to this situation. So in studies, cocaine has not been shown to be associated with worse treatment outcomes. It also has no difference whether someone uses cocaine, whether they're retained in treatment for their opioid use disorder. And cocaine use does not seem to increase self-reported opioid use. So what the evidence says is that, yes, cocaine is definitely bad for you, and you should discourage patients from cocaine use. Cocaine use disorder is a thing that you should treat. However, using cocaine does not contraindicate the use of buprenorphine or methadone or naltrexone for substance use disorder. In fact, people that use cocaine have a higher risk of overdose. So all the more reason for someone using cocaine to be on buprenorphine therapy. So what about marijuana? This is incredibly common. Many patients use marijuana regularly while they're using opioids, or they use it recreationally, or they don't even think about it as a drug, and it's just part of their daily life. Well, the evidence is pretty clear that marijuana use does not predict opioid use disorder treatment outcomes. And actually, one of the components of cannabis, cannabidiol, so the cannabis, when smoked, you get a combination of both THC and CBD. The CBD component actually has some randomized control trial level evidence that shows it's helpful in the treatment of opioid cravings. So sometimes what I'll end up doing is I'll advise patients to try CBD if they're using marijuana to help cope with their opioid cravings, and to try and stay away from the altering THC. But in general, there's no evidence to support telling a patient that, well, you have to be marijuana free in order to continue treatment with buprenorphine in my clinic. We should treat both conditions independently. And also, there's some
evidence that states with legal marijuana have seen significant reductions in opioid overdose rates. That's a correlation or causation argument there for sure, but there is some incidental evidence that legal marijuana might help decrease illicit opioid use. Well, what about comorbid alcohol use? So if someone's drinking regularly and taking their buprenorphine, is that a potential danger? Well, this one I'll say use with caution, because patients with comorbid alcohol and opioid use disorders tend to have more severe addiction and more severe impairment and often require more intense treatments than just office-based opioid treatment. Alcohol use is often correlated with opioid overdose deaths. So often alcohol is one of the mix of intoxicants that are found when someone overdoses. So what I counsel people is that I will still treat people with both comorbid alcohol and opioid use disorders. If they have both conditions, I'll strongly kind of lean towards naltrexone, which treats both conditions quite well. I don't recommend that when you're just starting out and you're just learning to care for people with opioid use disorder, that you take on somebody that has a severe alcohol use disorder and a severe opioid use disorder. It might be best to refer these patients to more expert level care. Well, what about smoking? Well, people that smoke tobacco have a higher incidence of relapse on opioid use disorder. They have like greater incidence of treatment failure. And people that are able to stop smoking while they're stopped in using opioids have significantly improved outcomes. So I'll use that to my advantage and never forget to address tobacco use disorder. So when I'm talking to people about opioids, I will also talk about cigarettes, and they'll be like, Doc, cigarettes are the least of my concerns. And I'll counter that assertion and say, you know what, actually, if you're really motivated to stop using opioids, you should also stop smoking at the same time, because there's really good evidence that stopping smoking helps people stop using opioids. And the reason why is kind of unknown. It probably has something to do with the addictive pathways and that repetitive addictive behavior that can trigger other substance use. So the thing to remember when a patient is using multiple substances is that the goal of caring for people with substance use disorders is harm reduction. We can't really effectively stop them from using all drugs. None of the national guidelines for caring for patients with opioid use disorder recommend stopping treatment when someone has a comorbid substance use disorder. Buprenorphine does not have a direct effect on any other substance use. So my advice to you is, if someone is using multiple other drugs, address the other substance uses. Talk about harm reduction, talk about safety of using those drugs, but don't kick them out of your practice, because that's the opposite of harm reduction. You're throwing the baby out with the bathwater, essentially. If you can get them on buprenorphine and treat their opioid use disorder, even if they have comorbid other substance use disorders, they're better off on the buprenorphine. All right, so let's go back to Tom for a minute. Tom starts to miss appointments, and he's trying to call in for telehealth. He says, Doc, I can't make the appointment. Let's do a virtual, or hey, can you just give me a bridge script and I'll make it next week. And next week comes and he's not there. At today's visit, when you're talking to him, he's visibly falling asleep. He's nodding. He has pinpoint pupils. Essentially, he looks like he's acutely intoxicated with opioids. And he's denying opioid use. He says, Doc, I'm just really tired, and I don't know why my pupils look this way. Says he's adherent to Sublocade every single day, and last took his dose this morning. Okay. So this behavior should make us a bit suspicious. And sure enough, we get a point of care urine drug screen, which you can see here on the left. And he's positive for buprenorphine, but also positive for fentanyl and opiates. So he's taking some fentanyl adulterated heroin, and it seems like he's also using
buprenorphine? Well, we're a little suspicious here, so we order a quantitative buprenorphine urine test. And on that quantitative results, we see something concerning. That sure, he has buprenorphine in his urine. All of the buprenorphine seems to be the unmetabolized drug. And there's only a tiny amount of the metabolized drug, the norbuprenorphine, that's 29 nanograms here. Remember, what you're looking for when you're looking at quantitative buprenorphine results is you want to see the metabolites greater than the unmetabolized drug. And in this case, we see that there is way more unmetabolized drug in this urine sample. We also see that the pH of the urine is slightly off. So what's up? This is consistent with spiking. So what spiking is a patient that's really trying to be savvy or trying to game the system. They know that we're checking for buprenorphine in their urine. So what they can do is take a little bit of that buprenorphine and they can put it in their urine sample. That way it shows positive for bup, but maybe they're actually not really taking it at regular amounts. You can also sometimes see this result if patients are taking the bup just right before the appointment. You'll see the bup level way higher than a norbup level. What they're doing with those other strips, you don't know, but you have to be regularly adherent to the medication for at least a few days to see more metabolites than you see on metabolized drug in someone's system. So unfortunately, it seems like Tom is spiking. Well, now what? Now we have examples of Tom repeatedly using other substances, and he's not being honest with us. What do we do? Well, this is what I like to call the last chance conversation. Tom's in trouble. He is potentially going to be referred to a higher level of care or told he can't be cared for in a primary care office. So again, the options are that refer to a higher level of care. So we don't kick people out of our practice in addiction medicine. We say, you know, there's a methadone clinic that I think you would be better served at because they have directly observed treatment. What I tend to do in these conversations is I reaffirm their goals. You know, when you first came in, you told me you wanted to stop using because you needed to get your life under control. And that really hasn't happened. So I want you to consider one of these other programs so that you can get your life under control. There's detox, there's partial hospitalization, intense outpatient or residential treatment. Those are all levels of care that are higher than just simply clinic-based treatment. And I'll recommend that the patient go to one of those. There's one more option to keep the patient retained into your practice that I often offer to patients is, okay, we're going to do this, but I know what is happening. This is what the urine results are telling me. I'm not accusing you of anything. This is what the urine shows. What I recommend we do is we're going to do this buprenorphine quantitative test at every single visit. We're going to do short interval follow-up. And I really think that you should consider some other kind of psychosocial treatment. So we know that bup alone is effective for most people, but in some people they need something else. They need some psychosocial support. So get them into groups or individual substance use counseling. And the other part I really like to make a part of my last chance conversation is a new drug called Sublocade, which is a depot buprenorphine shot that we're going to get into a little bit. So after having this last chance conversation, Tom says, you know, doc, I do want to stop. I admit that you got me. I have been spiking my urine because I was embarrassed because I got back on using heroin and I haven't been taking my bup. And I just want to stop, and I thought you would be mad at me. And I wanted to reintroduce myself. And now that you caught me, I'm owning up. But, you know, this Sublocade shot sounds good. I'd be willing to do that. So what's Sublocade? Sublocade is a once-a-month buprenorphine subcutaneous injection. This is a drug that's kind of revolutionizing addiction treatment because you can't sell your Sublocade. It's injected once a month. It's in your system. It continuously releases the drug, and it's associated with really positive treatment outcomes. It's a bit complicated. The drug says that you cannot start it directly because it can precipitate withdrawal. So you're not going to just start someone off the street on Sublocade. They have to be on sublingual buprenorphine. The package insert says that they should be on the drug for at least 8 milligrams for at least 7 days. but there are multiple papers saying that you could rapidly induce someone. So make sure that they take at least one buprenorphine dose and then get them on the Sublocade right away. Typical dosing for Sublocade is you give them a 300 milligram injection once a month for 2 months. Then you can drop down to the 100 milligram injection if they are no longer using and they're doing well, or you can continue at the 300 milligram dosing for patients that have more severe opioid use disorder. This is a difficult drug to acquire. It's limited distribution, meaning that you have to order it through a specialty pharmacy. And it has to be couriered directly to the physician's office. This isn't something that you can send to your local Walmart, have a patient pick up and bring it in. The reason why you can't have a patient pick it up and deliver it to your office is that it comes in a readily filled syringe with a needle. And if a patient were to administer this intravenously, which we know patients with opioid use disorder, have done in the past quite successfully, it would kill them because they would get an embolus and it would go to their brain and they could die. So it must be administered subcutaneously. What you do is you grab a piece of skin of subcutaneous fat, as seen in the picture there, in the transpyloric and transtubercular plane, as shown. And you inject it at a 45-degree angle as fast as you can into that subcutaneous fatty tissue. I will warn you that it burns. Patients will say that, that it really hurts. Some people says it feels like being stabbed. Some people says it just really, really burns, but it only lasts a minute. And people that are on this medication recognize it as life-saving and they will come back regularly. So our patient Tom, he gets his Sublocade and his life starts to change. He's not able to sell that buprenorphine. He's not able to divert it in any way. It's always in his system. He's not able to really use heroin because the Sublocade is there that's blocking, and it's blocking on a regular basis. So it's kind of taken the pressure of taking the Suboxone or the sublingual buprenorphine off the table, and now he's always using the Sublocade. Tom gets some counseling. He gets his Hep C treated. He becomes a stock photo model, and at his 1 year sober anniversary, he thanks you for not giving up on him. So even boss level patients, even those really challenging patients using multiple substances with multiple overdoses, you shouldn't get too intimidated by them because you can make a really significant difference in their lives by agreeing to treat them. And that's all I have for you for this talk. Thank you for hanging in there. I know this was a 2-hour and 15-minute talk. Hopefully you broke it up into a couple different bite-sized pieces. So I'm really happy to collaborate. I advise multiple different clinics on how to set up medications for opioid use disorder clinics and services. In the presentation that I gave, there's tons of different citations that are in the notes and in the PowerPoints themselves. Go ahead and read the citations that I presented, and I really encourage you to learn more about caring for patients with addiction. There's a bunch of really good books that I tend to recommend to people if they're interested in caring for these patients. One is Dreamland by Sam Quinones. It tells the story of the beginning of the opioid epidemic. There's Chasing the Screen by Johann Hari. It talks about addiction itself and how to end the drug war. The Dope Sick is another really great book about the opioid epidemic and the Sacklers in West Virginia. It's all now a great show on Hulu as well if you're interested in not reading a book and you want to see the TV show. It's pretty good. And Drug Use for Grown-Ups by Dr. Carl Hart is a very interesting perspective on harm reduction and how we could change our policies to better serve patients with substance use disorder. So thank you very much. My name is Dr. John Hayes. I'm a family and addiction medicine doctor, and I'd be really happy to collaborate with you in the future in caring for patients with opioid use disorder.